Morning, Shaylin. Did you forget to shave this morning, Eli?
Yeah. Luckily for me, I don't have to shave all too often, but
Oh,
I don't think you'll hear that fast. But
yeah, I have to hit it every day. Otherwise, I look pretty scruffy. Mine
yeah,
connects pretty well, but then it kind of stops growing after a while and it looks pretty ridiculous.
yeah.
All right. Well, good morning, everyone. We may have some people join us a little bit later. That's okay. So we'll go ahead and get started. We had the power turn off here just for about a minute, and it turned back on, fortunately. So hopefully it stays this way. So we are talking about hypertension and how to treat hypertension. And we're looking at the targets of hypertension. So the targets of hypertension, the targets of antihypertensive treatment will be the heart, blood vessels, and the kidney. So the kidney we saw last time has this group of cells, and this group of cells consists of these non-cuboidal cells in the distal convoluted tubule. These cells are right here, and was where these are cuboidal here, these are not, they're more columnar. And then these mesangial cells right here, they detect decreased blood flow through the afferent arteriole here that feeds into the glomerulus of the nephron. If you have decreased blood flow through the kidney, that means that the kidney is not being properly perfused and the blood is not being properly filtered. So these mesangial cells detect that, and the macula densa cells secrete this enzyme into the bloodstream called renin. Renin, as we saw, and this is essentially those same cells here. Here are those, you can see how tall these cells are relative to these other cells here. Here's the mesangial cells here. And you can see that the blood vessels are really close by. Here's the blood vessels feeding into the glomerulus. So these macula densa cells will release into the bloodstream renin. Renin release is also activated by the sympathetic nervous system. It is inhibited by angiotensin II, which is the product of renin release. And there's some drugs that stimulate renin release as well. So in the juxtaglomerular apparatus, there are beta-1 adrenergic receptors. When these are activated by either epinephrine or norepinephrine, the macula densa cells will release renin. Boy, trying to write with a mouse is not easy. So renin is a peptidase. It is going to target this protein that's in the blood called angiotensinogen. This is made by the liver. You can see this protein is not terribly big, 57 kilodaltons. The front of the protein gets clipped to this peptide here. Each of these represents an amino acid using the single letter codes for amino acids. This angiotensin 1 peptide really doesn't have any function that we're aware of, at least. It circulates through the capillary beds of tissues, in particular the lungs. The endothelial cells of the lungs have on their surfaces an enzyme called angiotensin converting enzyme, or ACE. ACE targets angiotensin 1. It takes these two amino acids and it's going to clip them off. And this peptide is angiotensin 2. Angiotensin 2 binds to receptors, and those receptors will do two things. It increases the production of the hormone aldosterone, and it causes vasoconstriction. Angiotensin 2 does not have an indefinite half-life. It's degraded by angiotensinase to angiotensin 3 that has no function. The angiotensin converting enzyme also inactivates this vasodilator bradykinin. Consequently, angiotensin converting enzyme is a target for antihypertensive drugs. Drugs that inhibit angiotensin converting enzyme decrease the amounts of angiotensin 2, increase the amounts of bradykinin. Therefore, they promote vasodilation. And those drugs do that without causing a reflex increase in the heart rate, like other vasodilators. That's one of the reasons why these drugs are so useful. Angiotensin 2 binds to its receptors. The main receptor is the AT1 receptor. The secondary receptor is the AT2 receptor. The AT1 receptor, when bound by angiotensin 2, increases vasoconstriction, thereby increasing systemic vascular resistance. Consequently, these receptors are targets for antihypertensives, and there's a group of drugs called the angiotensin receptor blockers, the ARBs. They work in a way similar to the way the ACE inhibitors work. Angiotensin receptor blockers, they are also antihypertensives. So to lower blood pressure, you inhibit ACE with ACE inhibitors. ACE inhibitors all end with the suffix PRIL, pril. And the angiotensin 2 receptor blockers all end with the prefix sartan. So you have in your notes lists of some of these drugs. I will call your attention to them. So on page 50 of your notes, notice that these drugs end in PRIL. These are your ACE inhibitors. So benzapril, captopril, captopril and alapril, fosinopril, lisinopril, moexipril, quinapril, ramipril, trandolapril. Those are all ACE inhibitors. They inhibit angiotensin converting enzyme. They prevent the production of angiotensin II. They increase production of bradykinin. They increase the half-life of bradykinin. Therefore, they lower blood pressure. These drugs are the angiotensin II blockers. They end in sartan. Sartan. Candesartan, eprosartan, irbesartan, losartan, olmesartan, telmisartan, valsartan. They all end in sartan. These are the angiotensin II receptor blockers. So in addition to the ACE inhibitors and the angiotensin II receptor blockers, there are also a grab bag of different vasodilators. These are not used for routine blood pressure control. They tend to be used for emergencies. Reason for that is that they have some long-term side effects that are not very desirable. So you have in your notes some drugs for hypertensive emergencies. These particular drugs are vasodilators, typically. And again, they're typically used for emergencies. So on page 60, page 61 and 62 and 63, there's a list of some of these miscellaneous vasodilators. Let's take a look at those. So clavipidine is a calcium channel blocker. Because this drug tends to really jack your heart rate up, it's usually only used after postoperative hypertension. After postoperative hypertension, you've usually been exposed to anesthesia, and that anesthesia usually causes your heart rate to be low anyway. So this particular drug is not going to jack your heart rate up very much. Now, nicardipine is used for routine hypertension. However, it's very good for hypertensive emergencies. Typically, at the concentrations at which you're using it, it's going to cause pretty severe tachycardia. But this is used for hypertensive emergencies. This medication here, sodium nitroprusside, that's only used for emergency. The beauty of this drug is that it is going to dilate arterioles and veins equally. So because it dilates arterioles and veins equally, it does a very good job of lowering blood pressure substantially. This drug is not to be used long-term because it can be degraded into cyanide. If you use it too vigorously, if you use too much of it, you can have thiocyanate toxicity. But it's good for short-term use. Penolvapam is also a drug that's Okay, let's get that focused. There we go. So phenoldiprem is another miscellaneous vasodilator. Once again, this drug causes tachycardia, also causes a monster headache typically. And this is to be used usually just for emergencies. And it's used for hypertensive emergencies. Nitroglycerin is given routinely, but nitroglycerin is also, if it's given by infusion, it's used for emergencies. Enalapril is a prodrug of enalapril. It is particularly useful for people with acute left ventricular failure. Because it's a prodrug, it'll have a slow onset. It's pretty useful, however, in an emergency setting. Hydralazine is another drug that can drop blood pressure pretty precipitously. It will usually cause a pretty remarkable increase in heart rate as well. Low concentrations of this drug can be given routinely for blood pressure, but it'll cause a pretty precipitous drop in blood pressure typically. That's another miscellaneous vasodilator. Labetalol is a beta blocker. If it's given intravenously, it's usually used for emergencies. Same thing with esmolol. Esmolol gets used pretty routinely in the ICU. Reason it's used in the ICU is that it works very fast and it has a short half-life. Metoprolol is another beta blocker. This has a longer half-life. So if you need something that works fast in the ICU, esmolol is your man. Metoprolol, if you want something that will last longer, say after the esmolol wears off, then you can give metoprolol essentially to make sure that the blood pressure stays good. This drug is particularly good after a woman has had a baby if she's suffering from eclampsia. It's also good for folks who've had a heart attack. These two drugs here are typically used in people who suffer from pheochromocytomas. So these block hypertension caused by catecholamines. Phenoxybenzamine is used before surgery. That's used to extirpate the tumors of the adrenal medulla. This inactivates the receptors that are bound by the catecholamines. This is particularly good for cocaine overdose. You don't want to use beta blockers for cocaine overdose because of a condition called coronary steal syndrome. This will not cause coronary steal syndrome. So this is also used to block catecholamines. So these, again, are some of those miscellaneous vasodilators. There's another one, it's really not used that much, and that's minoxidil. Minoxidil is a drug that's used for baldness. There's a topical form for baldness. There's also an oral form for baldness that's low dose. That's a vasodilator. You get pretty robust reflex tachycardia with minoxidil, so it's just not used very much anymore, except for pattern baldness. Now we come to the kidney and all the places where various drugs that are meant to work in the kidney will work. So the kidney consists of many, many structural subunits known as nephrons. So the blood feeds into the Bowman's capsule here. The Bowman's capsule is continuous with the proximal convoluted tubule. 65% of the solutes and solvent are recaptured by the proximal convoluted tubule. This is all due to active transport, by which you recapture various solutes. So you recapture glucose, you recapture bicarbonate, you recapture sodium and various other things. When you get to the loop of Henle, there's a thin loop of Henle and a thick ascending loop of Henle. The thin descending loop of Henle is permeable to water. You recapture a good deal of water. The thick ascending loop of Henle has these very powerful ion pumps, and the thick ascending loop of Henle is also impermeable to water. Those ion pumps recapture chloride and sodium and potassium. Then you get to the distal convoluted tubule. You recapture sodium chloride. You also recapture calcium in response to parathyroid hormone. And in the late distal convoluted tubule and in the collecting tubule, the filtrate then goes to the collecting tubule where it will then empty into the renal pelvis. Which then empties into the ureter, which empties into the bladder. This area is responsive to hormones. So it's responsive to antidiuretic hormone. In response to antidiuretic hormone, the cells, a group of cells called the principal cells, put in their membranes aquaporins. Those cells now recapture more water, so you make a more concentrated filtrate. Other principal cells up here also are responsive to the hormone aldosterone. Aldosterone is made by the adrenal cortex, in particular, the outermost area of the adrenal cortex, the zona fasciculata. This causes sodium recapture at the expense of potassium or at the expense of hydrogen ions. By antagonizing aldosterone activity, you decrease sodium uptake. You leave more sodium in the filtrate. By leaving more sodium in the filtrate, you leave more water in the filtrate. So these different areas of the nephron are all addressed by different drugs. So we'll now take a look at each of these different areas and how these drugs work. So the first are the carbonic anhydrase inhibitors. Carbonic anhydrase is found everywhere. So it's found all over the nephron. It's found both at luminal and basolateral membranes. It's found in the cytoplasm of epithelial cells. There's a soluble version of carbonic anhydrase that's found in blood. I'm sorry, it's just everywhere. Now, this enzyme catalyzes this reaction, the conversion of water and carbon dioxide to carbonic acid. Carbonic acid then disjoins to hydrogen ion and bicarbonate. There's no enzyme involved with this particular disjunction because this happens spontaneously. And then bicarbonate is this ion here. That's HCO3, this spiky thing. It just did that all by itself. So if you have more acid, that's going to drive this reaction in this direction here. And you will get rid of more CO2 in the lungs. Consequently, acidosis will tend to increase rates of ventilation. If, however, you are experiencing hypoventilation, either because you have chronic obstructive pulmonary disease, asthma, some other type, maybe pneumonia, something like that. Now, if you retain carbon dioxide, that will push the reaction in this direction, and you will have more acid. The kidney will then respond by getting rid of more acid. So bicarbonate is a remarkably important buffer in your system. So your body works very hard to keep bicarbonate, and here's how it does that. So bicarbonate in the filtrate, and this comes from the filtrate, binds to hydrogen ions. That hydrogen ion is released from the proximal convoluted tubule epithelial cell. So this is in the proximal convoluted tubule. There is an antiporter that brings in a sodium in exchange for hydrogen ion. That hydrogen ion combines with bicarbonate. It makes carbonic acid. Carbonic anhydrase, however, that's bound to the luminal membrane here, converts that carbonic acid to water and carbon dioxide. These can go straight through the membrane. Inside the cell, there's another carbonic anhydrase that will convert water, carbon dioxide, to carbonic acid. That carbonic acid disjoins to bicarbonate and to hydrogen ion. The hydrogen ion then, as you see, gets moved back to the outside. The bicarbonate then is removed by means of an antiporter. That antiporter is going to bring in chloride in exchange for the bicarbonate. Bicarbonate ends up back in the bloodstream. And this works because these two carbonic anhydrase isozymes work in tandem both outside and inside the cell to be able to convert carbonic acid into something that can easily traverse the cell, then to convert it into a charged moiety that cannot leave the cell, but can then be recaptured very effectively back into the bloodstream. Now, if you have, say, high altitude disease, if you have high altitude disease, you're hyperventilating. That hyperventilation gets rid of carbon dioxide. Because it gets rid of carbon dioxide, you're getting rid of acid. That produces alkalosis. What you want to do in this case is to keep more acid. So to keep more acid, you're going to rid the body of more bicarbonate. So in this case, you want to inhibit carbonic anhydrase. So carbonic anhydrase inhibitors do exactly that. Because you have more bicarbonate in the filtrate, you will lose more water. Because remember, there's no active transport of water in the kidney. Water goes where the electrolytes go. If you keep the electrolytes in the filtrate, more water stays in the filtrate. If you reabsorb more electrolytes, water follows the electrolytes. So these increase water loss and they increase bicarbonate loss. Therefore, they lower blood volume. Therefore, they lower systemic resistance, systemic vascular resistance, excuse me, and therefore they lower blood pressure. They're not typically used for blood pressure because depleting your body of bicarbonate can increase the amount of hydrogen ion and also can increase chloride loss, and that can have severe electrolyte imbalance problems. But they are given to people who have high altitude sickness. The main drug is acetazolamide, and it works by inhibiting those carbonic anhydrase enzymes. So here's the big gun. This drug is very inexpensive. It's very old. Works quite well. And notice these drugs tend to end with amide, acetazole amide, dichlorphen amide, methazole amide, brinzole amide, dorzole amide. These are your carbonic anhydrase inhibitors, not used so much anymore for blood pressure, but they are used for high altitude sickness, and they are used for systemic alkalosis. Loop diuretics work in the ascending loop of Henle. The ascending loop of Henle has those powerful ion pumps that deplete the filtrate of all those ions. Once the filtrate then gets to the distal convoluted tubule, the electrolyte concentration is quite low inside the filtrate. Because of that, the filtrate is going to lose more water to make the filtrate isotonic with the blood. If you don't deplete the filtrate of those electrolytes, when the filtrate gets to the DCT, it will keep that water. You will lose more water, you will lose more ions, you will decrease blood volume, and you will decrease systemic vascular resistance and decrease blood pressure. So here is your thick ascending limb of the loop of Henle. Loop of Henle. There we are. Here are those powerful pumps right here, and the loop diuretics are going to inhibit that pump. If you inhibit that pump, you're going to leave lots and lots and lots of these electrolytes in the filtrate. You leave more electrolytes in the filtrate, you leave more water in the filtrate. You increase water loss, you decrease blood volume, you decrease systemic vascular resistance, you decrease blood pressure. And then that goes out in the urine. Loop diuretics are the most effective diuretic group. They work very, very well. Big caveat of these particular drugs is you have to watch electrolytes. Patients can lose a lot of electrolytes with these drugs. So here are your loop diuretics. So furosemide, this is a drug that goes by the trade name Lasix. The reason it's called Lasix, that's meant to be an A. Oh, come on, you, come on. S-I-X. It's called Lasix because it lasts 6 hours. So it lasts 6, Lasix. That's how it got its name. This drug is very inexpensive. So it's cheap and it works. It works very well. Bumetanide is the other one. That's Bumex. Torsemide is Torsex, I think, but it's available now as a generic. And then ethacrynic acid. This is a very important loop diuretic because these other loop diuretics, you'll notice, have sulfur in them. And if someone has a sulfur allergy, you cannot use these drugs, but you can use ethacrynic acid because ethacrynic acid has no sulfur in it. Loop diuretics. Thiazide diuretics work in the distal convoluted tubule. In the distal convoluted tubule, there is a sodium chloride symporter. This recaptures sodium and chloride ions from the filtrate. By recapturing sodium and chloride from the filtrate, you recapture more water. Remember, water follows the electrolytes. Thiazides also will help recapture calcium. Therefore, thiazides are also used in patients with osteoporosis. Oh, look, it's snowing. Great. So here's your distal convoluted tubule. Here's your sodium chloride transporter because you're losing electrolytes, you're losing charge. You're going to also passively take up calcium. Thiazide diuretics inhibit that pump. You leave more solutes in the filtrate, you leave more water in the filtrate, you lose more water. Therefore, you lower blood volume, you lower systemic vascular resistance, you lower blood pressure. Thiazide diuretics typically will have the name thiazide in their sobriquet. So here, for example, on page 47, of your notes, page 47. So bendrofluormethiazide, see the name thiazide, chlorothiazide, chlorthiazidone. So that's the exception, thiazidone rather than thiazide. Hydrochlorothiazide, indapamide, metolazone. So these are the exceptions here. So let's put those in a different color. But these others have thiazide in their name. And on another page, I have the loop diuretics. Huh. Doesn't look like I have the loop diuretics listed anywhere.
I think it's on page 43.
Page 43. Oh, good gravy. There we are. I skipped right over that. Those pages look like they stuck together. So bumetanide, Bumex. There's furosemide Lasix. That's the one that's used the most, probably. Demodex, there's torsemide. And then ethacrynic acid. Edicarin in generics, and there's your loop diuretics. Now, your potassium-sparing diuretics work in the late distal convoluted tubule, and they also work in the collecting tubule. They are typically going to antagonize the activity of aldosterone. That's pretty much how they work. So they will inhibit sodium channel recapture of sodium. They inhibit the secretion of potassium, therefore they will keep potassium. They'll conserve hydrogen ions and potassium. They are not terribly powerful diuretics, so they will tend to be used in combination with other things. There are situations under which these diuretics are very useful. Reason being, most of the diuretics we've talked about, you lose quite a bit of potassium. These can prevent that loss of potassium. So here are the principal cells. The principal cells recapture sodium, and they do so at the expense of potassium. And of course, you recapture water. If this is the aquaporin, that's in response to ADH. These two channels, the genes for them, are expressed in response to aldosterone. Aldosterone binds the aldosterone receptor. That activates transcription of these channels, and you recapture more sodium and get rid of more potassium in the filtrate. That's in the principal cells of the collecting tubule and the late DCT. These two potassium-sparing diuretics, spironolactone and eplerenone, are aldosterone antagonists. More accurately, they're aldosterone receptor antagonists. They gum up the aldosterone receptor. They prevent it from being able to bind aldosterone. Therefore, the expression of these two channels diminishes substantially. You keep more sodium, therefore, in the filtrate. You therefore keep more water in the filtrate. You lose more water, you lose more sodium, and you keep more potassium. Spironolactone is very inexpensive, and it's used quite a bit. Has some caveats, especially for males, side effect-wise, but it's a very good drug otherwise. Other potassium-sparing diuretics are going to act directly with these channels. So amiloride and triamterene are not aldosterone receptor antagonists. They antagonize the sodium channel. Because they antagonize the sodium channel, they prevent the reuptake of sodium. Now, as you look at the structure of these drugs, something I really want you to see is that spironolactone is a steroid. Therefore, this drug, side effect-wise, is going to have certain steroid disruptive side effects. Eplerenone is also a steroid, but it does not have the same side effects that spironolactone does. Triamterene and amiloride are not steroids. That is very significant for their side effect profile. So we'll say more about those when we get to those particular drugs. Very good. That's my introduction to some of the drugs that are used to mitigate blood pressure. Let's talk about some of these in more detail. In particular, let's discuss the beta blockers. Beta blockers, what are they good for? Well, they're good for a whole lot of things. So if we think about the peripheral nervous system, the peripheral nervous system is divided into a voluntary, the motor neuron system, the somatic nervous system that controls the voluntary movement of skeletal muscles, and the autonomic nervous system that controls the involuntary movement of smooth muscles. Smooth muscles in our glands and our organs and blood vessels and things like that. The autonomic nervous system is also divided into the sympathetic and parasympathetic branches of the autonomic nervous system. And if we think about the sympathetic branch of the autonomic nervous system, there are several different receptors that are used by targets of the autonomic nervous system. These different targets are very important because it means the same neurotransmitter can give you very different results given these different targets. So alpha-1 adrenergic receptors, they are found in most of your vascular smooth muscle that's innervated. They're also found in papillary dilator smooth muscle that controls the eye. So when it comes to pupillary dilation, that's the receptor responsible for dilation of your pupil, the alpha-1. They help your hair stand up on end when you get scared. So if you're playing Resident Evil or something like that, and the hair on the back of your neck stands up, it's due to sympathetic input to these alpha-1 receptors. Contraction of the prostate is also the result of alpha-1 receptors. And in the heart, they can increase the force of contraction. Alpha-2 receptors are pretty much restricted to the central nervous system. And here they play an autoregulatory function. This autoregulatory function is that they prevent noradrenergic neurons from releasing excessive amounts of norepinephrine. They're also found on the surfaces of platelets, fat cells, and just a few smooth muscles of blood vessels. The alpha-1 are definitely the major ones in that regard. Now, the beta-1 receptors are found in the heart. It's not listed here, but they're also found in the kidney. In particular, the juxtaglomerular apparatus of the kidney. When they are activated, they will cause the release of renin. But in the heart, activation of the beta-1 receptors increases the force of contraction and also the rate of contraction. Beta-2 receptors, they are found in respiratory, uterine, and vascular smooth muscle in places like skeletal muscle. So this is a reason why exercise increases blood flow to skeletal muscles. You're getting vasoconstriction in other places and vasodilation in muscles that serve, smooth muscles in the vessels that serve your skeletal muscles. They're also found in the liver, where they activate the breakdown of glycogen. There are also beta-3 receptors found in fat cells. They activate the degradation of fat. Dopamine receptors, these respond to dopamine, and they can either dilate blood vessels, but they can also increase the rate at which the heart contracts. So, for example, dopamine is given in the ICU as a vasopressor. That's due largely to the fact that it will increase the rate of the heart. Because you get some vasodilation, you don't get as robust a response, say if someone's in shock, as you would with other drugs. So beta blockers are going to address these two receptors mostly. Some of them will be more specific for the beta-1 receptor. Some of them will inhibit both beta-1 and beta-2 receptors. So in general, the beta blockers will antagonize beta adrenergic receptors. The ligands for beta adrenergic receptors are norepinephrine and epinephrine. Because these drugs inhibit components of the sympathetic nervous system input, they are referred to generally as sympatholytic drugs. Sympatholytic drugs. A few of the beta blockers are partial agonists of beta adrenergic receptors. So they don't just bind to these particular ones. They don't just bind to the beta blockers and antagonize them, prevent epinephrine, norepinephrine from binding them without activating the receptor at all. Some of them actually activate the beta receptors just a little bit. So they are partial agonists. So these particular ones with the partial agonist activity have intrinsic sympathomimetic activity. Intrinsic sympathomimetic activity, ISA activity. Mind you that ISA activity is not full sympathomimetic activity, it's partial. But they have some activity, therefore they will not cause nearly as much sympathoplegia as the other beta blockers. Beta blockers also have some membrane stabilizing activities. That's going to be pretty important when it comes to the ability of these to calm down a heart that is just beating too fast. So some beta blockers are non-selective. They block both beta-1 and beta-2 adrenergic receptors. Typically, those beta blockers will begin with letters going usually from A to about L, usually. Second generation beta blockers are cardioselective. Typically, they will have letters that begin with M all the way to Z. Third generation beta blockers, there's two of them, labetalol and carvedilol. These also can block vascular alpha-1 adrenergic receptors. Those are special case beta blockers that are typically used for patients with heart failure. We'll talk about those in just a bit. So if you activate beta-1 adrenergic receptors in cardiomyocytes, so this is a cardiac myocyte you can see here. In the cardiac myocyte, you activate adenylyl cyclase that increases the amounts of cyclic AMP. Cyclic AMP activates protein kinase A. Protein kinase A has several targets. One of those targets increases release of calcium from sarcoplasmic reticulum stores. That increases contraction because more calcium increases more contraction. Protein kinase A also activates L-type calcium channels. That increases influx of calcium. Influx of calcium increases calcium release. Remember, in cardiomyocytes, you have calcium-dependent calcium release. That increases contraction, both the rate and the force of contraction. Now, what if this was smooth muscle instead of cardiac myocytes? Now, it's not quite so simple, is it? It's not quite so simple because in smooth muscles, cyclic AMP inhibits myosin light chain kinase. So if we were to talk about vascular smooth muscle cells, cyclic AMP inhibits myosin light chain kinase. Since myosin light chain kinase phosphorylates the light chain of smooth muscle myosin, and since inhibition of myosin light chain kinase prevents myosin from being active in smooth muscles, activation of the beta-2 receptors in smooth muscle will produce less contractile force and will therefore promote relaxation. So here, you're going to get relaxation. That's a different response than what you get from cardiomyocytes. I'll just say relaxation. I won't write out relaxation. I'll just write relax. So beta blockers decrease the heart rate. The heart will beat more slowly. Therefore, they show negative chronotropy. Chronotropy. And if you look here, it's due to the fact that they prevent activation of adenylyl cyclase. Since you can't activate adenylyl cyclase, you don't make cyclic AMP. Cyclic AMP levels therefore go down. Cyclic AMP levels go down. You don't get as much calcium coming into the cell. You don't get as much calcium-induced calcium release. You don't get as nearly a fast a level of contraction. And so the heart rate goes down. So they show negative chronotropy. They also decrease contractility. Again, decrease calcium, decrease contractility. Therefore, they show negative ionotropy. Sorry, inotropy, negative inotropy. They also decrease the rate of conduction. Rate of conduction turns out to be pretty dependent on those L-type channels. So they decrease conductive velocity. They have negative dromotropy. And they decrease the relaxation rate. Because they decrease the relaxation rate occurs much more readily. So they show negative lusitropy. Negative lusitropy. So those are the effects of beta blockers in the heart. And this is the case in the beta 2s. The intracellular cyclic AMP inhibits myosin light chain kinase. Since it inhibits it, you promote relaxation. So blockade of the beta 2 receptors is associated with some degree of vasoconstriction in vascular beds. However, the effects of the heart vastly outweigh whatever effects you might get in vascular beds. Therefore, the drop in blood pressure is much greater than any potential rise in blood pressure with beta blockers. And this shows you the cell biology, essentially, of smooth muscle. Where activation of the beta 2 adrenergic receptors also activate cyclic AMP production, but in this case, you're promoting relaxation because you're inhibiting myosin light chain kinase. And as I look at the clock, we're out of time. So we'll finish up there. We'll continue this on Monday. So have a great weekend and enjoy your time off.
Thank you.
You're very welcome.